Okay, so basically what we are going to do today is we're going to talk about adolescent, medicine, because there are one of the questions which challenges which most people feel, especially Indian candidates, are when you're dealing with adolescent medicine. I think Tanushi, you have been preparing a bit, so as from what I can make out, so you know that, don't you? Yeah, yeah. You can unmute yourself because it'll just be interesting rather than just me saying one monologue. It'll be interesting if we talk to each other. Yeah. So, what do you think about adolescent pediatrics?
So I've been a member of this Adolescent Health Academy, and I'm
Oh yes,
practicing
I know.
adolescent medicine actually.
Do you actually practice adolescent pediatrics?
Yes,
Yeah.
yes, sir. Yes,
Oh,
sir.
so well, then you are one of the exceptions. Because in India, as you know, we are very much behind, isn't it? As far as adolescent pediatrics is concerned. In India, most
My
most
8-year-old
people,
with an adolescent daughter.
yeah. So that now you would be able to tell better. But this is very recent, isn't it? Because all this awareness about adolescent pediatrics and a lot of work is being done by, obviously you are there, Dr. Shomik Ghosh, and the whole lot of doctors there working.
Yes,
But in
yes.
India, as you know, the problem is when you go for, I'll speak to you directly, I'll just, my recording, yeah. So basically, the concept is when you are going for a UQ exam, why do you think Indian candidates struggle? Any answers? Why do you think we struggle compared to a UK candidate, and especially in theory exams? Why do you think we struggle? What could be the cause? Sometimes they just sail through, and we struggle a lot with a lot of standard things. Which Why do you think that happens? Anyone? You can use the chat box if you want, or you can answer. See, it is
During our
important to know
postgraduate
this.
training,
Yeah, say that,
during our
Tanushree.
postgraduate training, what I feel during our postgraduate training, there are certain fields of pediatric practice which was not touched upon actually. The kind of training we had, that was way back in 2004 or 5, quite early. Now probably the scenario must have changed, but I'm talking about during my time. I don't remember having a chapter in adolescent pediatrics. I
Absolutely.
don't remember having a chapter basically about substance abuse, addictions, the kind of problems that
Yeah,
adolescents today face.
yeah, you're
So
right.
these were not dealt upon, and our mode of study is way different from what we are doing now in the MRCPCH.
Absolutely,
The
absolutely,
yes,
absolutely. So, Dr. Smita, I've not seen your face. I guess you're feeling very shy. But do you want to answer? Do you have any? Because this is important to know why the theory, why we struggle. Because unless you know that and you're going to give the exams, you have to have an idea. So you can unmute and say, if you don't want to show your face, I understand. Uh, any 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 thoughts about why we struggle with the theory part? FOP, TAS, AKP, where do we struggle really? And why? That's why you should be aware that these are the points I need to concentrate on. And that's why I brought up adolescent health today. So, Dr. Smita, do you want to unmute and tell? Yeah. Hi there. If you're still there,
Yes, yes, I'm still here, sir.
yeah. Are we allowed to see your face, or are you feeling shy?
No, no, actually.
We can see. I won't bite, as I said. There we are. Now we know who's Dr. Smita. So, where are you, Dr. Smita? Just tell me where you are based, so we all know where you are.
I'm in Mumbai.
Oh, brilliant. I just came back from Pune. Lovely place. Okay. All right. Okay. So just tell us, because it's nice to be interactive. That makes it fun. So why do you think? Because you're obviously going to give the MRCPCH theory exams and all that. So why do you think we need to know? Isn't it that before already appearing for exams, the UK exam? Why do you think we struggle? Indian candidates, where do they struggle with the theory part? Any idea? Any
Uh,
thoughts?
I mean, I think so. Seeing the question pattern, I think so. I'm struggling
Yeah.
everywhere
But
because
particularly when if you compare with Indian exams, DNB or Indian pediatric question, there is as you know, there is a difference, isn't it? The pattern and all. There's
it's
a difference.
it's like most case scenario based rather than just
Yeah,
just a theory to describe this or
absolutely.
describe that.
Absolutely. Absolutely. Very, very. So thanks, Vita, for coming forward. Really appreciate that. Okay. So thanks for being brave and coming up on screen. Yeah. So that's it really. Because basically these are, first of all, yeah, there's a more scenario based. It's
Hmm.
not too much of theoretical. If you see, the theory is comparatively less theoretical knowledge. It's more of how you apply the knowledge to practice.
Oh.
Tanushri, will you agree? When you go through the papers, you'll find it's more about, there is FOP and task where you have some theory information, but most of the questions, it is how you're applying, even if it is basic sciences as well, how you're applying to clinical cases or how you're applying to your practice. That's where the thing is.
I would
Yeah.
say it's a big relief for us that questions are critical, because for myself, I passed out way back in 2005, 6. So my theory knowledge is very poor, but I've been practicing for so long, so my practical experience is rich. In that way, what I
Absolutely.
find, I'm quite comfortable with the FOP questions, because it's clinical
Absolutely.
based and I can use my
Absolutely.
clinical knowledge.
Okay.
I'm not
And
a
that's the
theory
reason.
person. I don't theory, physiology,
Absolutely.
anatomy, something is very difficult.
Awesome. So that's the good thing about this exam is that it is very much whatever you study will be related to your clinical practice. It will help you in a clinical practice. So even if your theory, so you have to brush up, some of the theory part, because obviously if you're out of touch, we are not doing. It's not that we passed MBBS just a few years ago. We have passed MBBS some time back, or even if you have done a post graduation a few years ago. So we are out of touch with theory, but whatever you read will be linked to that. Anyway, so I won't waste your time. So adolescent health, one we picked up because what we find is most candidates, myself as well, we used to struggle with these topics. Like the last one I did was, the first topic I did was, as I said, I'm planning to do a series of, free sessions, which will be hopefully every Monday. But if it's not a Monday, then I'll probably do on a Wednesday. So do watch out. And these are usually topics which I think we Indian candidates, especially we struggle with. So I'm particularly picking up those type of questions. All right. And you're free to come and join. You're free to bring your friends if you want to. And I hope it gives some direction what we are. At least I struggled a lot during my theory exams.
Pranali Das is my classmate. I think she joined your
Oh,
class. We
yeah.
studied
She's
together.
okay. She's just passed her exams, didn't she? She passed the clinical.
Yes, she is
Yeah.
my MBBS classmate. Post graduation,
Oh,
of course, she did later, but she's my MBBS classmate.
okay. All right, all right. Well, she just cleared the exams and we're so happy for her. Well, tell her about you when I next meet her. So, okay, so the adolescent health, because in pediatrics, what happens is in our pediatric ward, pediatrics, these come, we don't see adolescents. Isn't it? How much of adolescents do you get unless Tanushri, you are specializing in adolescent? But in general pediatrics, see, as far as I know, my patients are maximum 10-year-old, and they assume that after 10 it is some adult patient or something. I don't know why, but in India that's the case. Whereas in UK, you need to know that the adults till 18-year-old, the patient is all pediatrics. It's all pediatric. You have to know this very clearly. And adolescents by themselves have very specific problems, which you have to be aware about, and which are you have to have different set of skills, and you have to be quite, sensitive, and you have to deal with very a lot of medical legal issues. So you have to be aware about that. So can someone tell Jayanti or Neetu what are the issues with adolescent health you can think about, which might come up in exams or which which you think are major issues? So you can put the camera on, very briefly tell if there's any particular issues you think about in adolescent health, which could come up in the exams or which probably we deal with. Yeah, Neetu, thanks for putting the camera on. You can unmute and talk. Yeah.
Mostly the drug abuse, problems of drug
Yeah.
abuse will be there.
Very good.
And
Very good.
the other one is sexually transmitted infections.
Absolutely. Absolutely. So there are
And
issues with that.
then other like eating disorders, anorexia, bulimia.
Exactly. Absolutely. Yeah. So you brought up the very common things which are very common, and they are quite challenging, as you know. They're not very straightforward. So you have to, this exam is preparing you for that's where you're registrar on the pediatric wards, and at night you'll be dealing with these issues. So you should have some basic understanding how to deal with that. That's, I think, very good. So Jayanti, do you want to bring up anything? Anything else you want to add? What else do you think, could be the problems when you get teenagers? What else do you think you would be managing?
There can be behavioral problems.
Yeah,
Then
behavior problems.
this is the age group where adolescents come across, in school problems to achieve marks, stress disorder. They will be exposed to more stress.
Yeah, absolutely. Stress and all are obviously there in India as well, and obviously with class 12 and 11 and all. But yeah, there are obviously a lot of study, expectations to do good with your studies.
Yeah.
So there are anxiety problems. You said behavior problems. There are stress disorders. So we'll keep that at the back of our mind. And what we'll do now is we'll share the screen now. Okay, I'll just make sure that I've got the thing right, and then we'll share the screen. Okay, just. Let me just see if I can get the zoom on. Just see. So can you see now?
Yes.
Yeah, visible.
Yeah,
So we
yeah.
are talking about adolescent health. Now, the topics we'll talk about, they are not, hugely difficult questions or anything, but at least we want you to see how you're thinking, what's your line of thinking. And as I said, see, a lot of people ask me, oh, I'm doing AKP exam, some, oh, FOP test. Well, the questions we talk about, believe me, in the real exam, it is not that sharply demarcated, okay? There is a lot of common ground. So you cannot say, oh, I'm only doing AKP, so I'll only do. No, the way we design our course and our teaching and what we've learned as well, there's a lot of common ground. There are very specific things which are different for FOP test and AKP, but generally there are a lot of common ground which you should be very aware about. And in fact, some of these questions which will deal with the topics, we'll also have to be aware because in the clinicals also, when you come to the clinicals, a lot of these questions might come up in clinicals in some form or the other. So we've tried to select the questions such a way that it's an overall holistic approach to adolescent health. Okay. So obviously it's a vast topic. There are lots and lots to cover, but we are just taking a few standard basic questions and we'll take it from there. All right. So what I'll do, so let's do the first one and someone can have a look. I think Tanushri, you can, if you know the answer, please don't tell the answer unless we ask you, okay? Because let's give others a chance. So Tanushri, you can read it if you want. And
Yeah, a 14-year-old girl. Am I audible?
yeah, I can hear you. Yeah.
Yeah, a 14-year-old girl, she's concerned because she feels that she's not developing like her friends. She likes school and reports that she's doing well. On examination, she looks well and is between the second and ninth centile for her height and ninth centile for weight. She has breast studs and sparse pubic hair. Olfactory and ophthalmic functions are intact. Blood tests reveal that she has normal LH and FSH levels. What is the most likely cause of a pubertal delay?
So even when you've gone through the question, so even before, there are some choices there. But what are the common things of pubertal delay you'd like to think about, even before you see the choices? Because in the real exam, that's how you're supposed to approach the question. Before you see the answer choices, you should have some idea, basic idea, what could be the causes of a delayed puberty. Any idea anyone can add? You can use the chat box and
Is it androgen insensitivity? Because the LH-FSH level seems to be normal, which is a sign that probably her hypothalamic, the androgenic part is lacking here, as her secondary sexual characters have not developed as it should. And plus, this is a 14-year-old girl. We can't say it's delayed puberty because puberty did start, but somewhere down the line, it has delayed.
there is some delay because she's obviously, that's the question really. Yeah, so she's now, I think, how old was she? She's now.
The menarche has not started.
She's 14-year-old.
In a girl who doesn't have menarche by 13 years old, it is said to be delayed puberty. So she has not started her period, right? Yeah. So,
yeah, that's what they have given. We just have to go by what the question is. Anyway, let's see what the choices are. So let us be aware of what the choices are. Yeah. So we need to aware of what is what actually, and take it from there. So Neetu, Smita, Jayanti, any wild guesses or any thoughts? You can type. You don't have to give the right answer, but any thoughts what it could be and why?
It's a constitutional delay, probably.
Okay, that's fine. That's the choice. Neetu, Smita, Jayanti, you need to make a choice really.
I also go
Constitutional,
for constitutional
okay.
delay.
Yeah, I think could be anorexia nervosa also, because her weight and no, sir, this is anorexia nervosa because her weight and height are all below the percentile, and it can often present as anorexia nervosa.
So Tanushree is backing a different horse now. Okay,
Yes,
she's gone to anorexia
anorexia
nervosa. So Jita and Jayanti has committed to constitutional. Neetu and Smita, we're waiting for you guys.
The constitutional delay does not happen in girls. I just forgot that. It's mostly a diagnosis made. It should be a diagnosis made in boys.
Okay, Neetu, Smita, what do you have in thought? Just commit yourself. Don't worry. See, in the exam, this is what. See, that's why we do the.
I feel it's
just type in there. Yeah, just type in the chat box because that will help. And who's that? Smita or Neetu?
I go for constitutional delay.
Neetu. Sorry, if you
Can
don't
you
say
hear
your name, we can't understand who's speaking. It's Neetu, I guess. Yeah, you're saying constitutional.
Yes.
Okay, why is that? Okay, anorexia nervosa. Anushri has said anorexia nervosa. She has committed. Smita is keeping quiet. She'll see
I
which is
feel
the
it's
majority choice.
constitutional delay.
Why? You have not typed it. That means you're not sure. You only
Basically,
typed that only.
she's doing well in school. She's feeling good, she says. So I don't know. Anorexia nervosa won't be there. I don't feel that.
What about that chart and all that?
Where?
You talked about the weight chart and all that. Second and ninth centile. Is that okay? What do you think?
No.
And what do you think?
Delay. She's falling behind.
So 9th and 9th centile for her height and 9th centile for the weight. And what is this thing about olfactory and ophthalmic functions and all that? Why do you think they're saying that?
Kallmann syndrome.
Yeah. So what happens in Kallmann syndrome? What happens in Kallmann syndrome?
Anoxia. There is anoxia, sir.
Very good. Who's that? Good answer. Who's that?
That's me, Tanushree.
Is that Tanushree you're saying?
Yeah.
Yeah. So that's good. So that is about the this thing, Kallmann. So you have to have some idea what Kallmann. And why they're saying that olfactory and ophthalmic functions intact. Is that only because of that? Ophthalmic functions. See, every word has a meaning, isn't it? There's something. So, when you get the exam, you have to think how, why you're thinking along the lines.
It is trying to point out the pituitary functions are probably intact.
Yeah. Very good. Very good. Okay. And she likes school and all that they're saying. Right. So, like school means usually anorexia and all, what would happen? So, craniopharyngioma, tell me how would that present?
Craniopharyngioma is a pituitary tumor which will present with access of association. Okay, one thing.
Smita, do you want to say do you want to help? Because Tanushree is, doing everything, but she's trying a lot, but do you want to help her? How would craniopharyngioma present? Hello? Jayanti, Smita, Neetu.
The gonadotropin releasing hormones will be high because it will be central precocious puberty. Craniopharyngioma is the cause of central precocious puberty. Okay. So the LH FSH would also be high, sir, in craniopharyngioma.
I just want to see what others are feeling. Anyway, so why is it not anorexia nervosa? I think was it Smita or Jayanti who said. Why is it not anorexia nervosa?
She's doing well in school. And she likes to go to school. Whatever she's interested in activities.
Okay, and the weight and all? Okay. So let's go through the answers. So That was the right answer, constitutional delay. All right, that's the right answer. Now let's go through the reasoning. Okay, so Tanushri, back the right one and then back to you. She did overthink. See, this is what happens in real exams. So basically what I will go through in brief, okay, because lots of explanation. It's given in detail. But basically they are all due to hypogonadotropic hypogonadism, but the commonest cause is constitutional delay. I think we all agree with that, isn't it? Commonest cause is constitutional delay. And see, the LHFH is why the ratio is done, because it helps to delay and classify the cause of delayed puberty. So elevated gonadotropin is usually gonadal. Basically, it's a primary gonadal problem. That is one of the causes. It is a primary hypogonadism or gonadal, some sort of problem in the tumor or something. That's all. Low normal gonadotropins are hypothalamic hypopituitary disease or secondary hypogonadism. So that is a secondary cause. Or as we talked about, hypothalamic or hypopituitary. Now they will go through the way they're approaching is differentiating constitutional delay from idiopathic hypogonadotropin. It's difficult. And basically so differential diagnosis between these two, constitutional and idiopathic hypogonadotropin. But in reality, constitutional delay is the commonest, so that's why they're going by that. But differential diagnosis of, if you go by hypogonadotropic hypogonadism, constitutional delay is the commonest. But as you can see here, they have put the list, which you can find in a textbook. But briefly, if you see, I think you did mention that also. I think a lot of it mentioned that congenital deficiency, so hereditary hypogonadism, idiopathic, IHH, Kalman, Prader-Willi, Bardet-Biedl syndrome, and obviously receptor defects. Acquired is functional. I don't know what is functional really. I can't explain that. But chronic disease, we talked about anorexia nervosa, excessive exercise, somewhat similar. Hypothyroid, hyperprolactinemia. Anatomic tumors, we know they are because of craniopharyngioma, pituitary tumors, but we didn't have the features of that. Head trauma, some opiates, some marijuana, and some sort of infiltrative disease. It's good to have a brief idea what it is like. Now here, because the main, I think we were getting confused with the anorexia. I think Dhanushri, and I think we were also, that was where we were getting a bit confused. See,
the confusing thing was the weight and centile, like.
Absolutely. But see, we are coming to that. And see, that's interesting, Dhanushri, because you see how the reasoning is happening. See, first of all, less common. And what they're saying is child is unlikely to be on greater weight centile than height centile and look well if they have anorexia. They said very clearly, if you look at the question, Look at the question. See very quickly. She looks well and between the second and ninth centile for her height and ninth centile for her weight. So weight is on the higher centile. Height is between the second and ninth centile. So how can it be? So weight is better than the height, in fact. So just be, all I'm trying to say is tricky. So, exam, they are trying to trick you to some extent. So just look at try to think, what is the trick really? So each and every data has to be analyzed. Okay, that's why I was trying to get you to see how you're thinking, your thinking process. So that's that really. Now what they're saying is obviously anorexia it could have easily been they could have given that also. How it is always important to be aware of potential diagnosis of anorexia. So they are saying it's a good differential diagnosis. You cannot ignore. This one really. Now, usual symptoms for craniopharyngioma, I think you said headaches and visual disturbance. They did mention about something about visual and all that, isn't it? I think they did mention that. So there was no visual problems. So there it's gone. It would be unusual for a child to present with delayed puberty without any other associated features. So craniopharyngioma is a cause, but there will be some symptoms. Now I think we go through these ones as well. Let me just this one. Yeah. So if you go through these one, Kalman's, I think you got it right. Someone said Kalman's it is associated with hypogonadotropic hypogon with anosmia. I think Tanushri, you said that. But here they're very clearly saying that olfactory function is intact. Bardet-Biedl it is basically, because we keep forgetting, it's retinitis pigmentosa, obesity, polydactyly, mental retardation, and hypogonadism. Now the question states that she is on the 10th centile for weight and is doing well at school. So obviously obesity is ruled out. And there is no mention of any visual problems. So that's why that one is ruled out as well. So, so I hope, just shows how they have come to the different, how you're ruling out the differential diagnosis. So doing well at school means obviously she's not having visual problems, not doing unwell in her studies. 10th centile for weight means definitely she's not obese. Okay, so is that helpful? Yeah?
Yes, yes, sir.
Are they? Yes. So because I want to know that people are awake. Otherwise, you're dozing off,
Yes,
then no
yes,
need for
yes.
me to. That's good. Let's get the energy levels. Otherwise, no good at 9:30. I could be seeing Netflix by now. There are some good movies there. So you need to show that yes, you are also there with me. Your energy is there. Then I can carry on. Okay. So are we going happy for the next one? Next question. Yes. Bring it on.
Yes, sir.
Hello.
Yes,
Yes.
yes.
Bring it on.
Okay. Yes. 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 Okay. Some more questions. Someone is saying yes. Right. Next one. I'd like Neetu, Dr. Neetu, just go through this question, please. You can put your camera on and just go through this question. Everyone will help you. Don't worry. It's not only your problem. So others. Yeah. Please carry on.
A
Can you
15-year-old
see?
girl,
Hmm.
yes, yes. A 15-year-old girl is brought to see you by her mother, who is worried about her behavior. The girl denies there is any problem, but her mother mentions that she has become withdrawn, less energy, her hair is thinner, and thinks she have lost weight. Uh, there's some abnormal behavior, sir, and also there's some withdrawal
Unusual
symptoms,
marks.
the lack energy, and also there is unusual marks on her hands. So most probably anorexia nervosa.
Okay. Anyone else? Any other thoughts? Jayanti, Tanushri, anything? Nita. So these are the choices. Hypothyroid, cannabis abuse, bulimia, hyperthyroid, anorexia nervosa. Any thoughts? So the problem with the behavior, the girl says that no, she's not having a problem, but she's quite withdrawn, lacking energy, become thin, lost weight, some marks on the hands. What could it be? Anyone?
It could be some substance abuse, sir.
Sorry?
Cannabis use.
Cannabis, is that Jayanti? Yeah. Anyone else? Smita? You have to give some, logic, reason why you're thinking of that. So that's how the exam is trying to rule out, really. So why you think of cannabis? Behavior problems.
Cannabis, these symptoms of being withdrawn, lacking in energy, may
What
have
is this
lost some
marks
weight.
on the hands? Some marks on
Yes,
the
that is
hands.
what. That is why I'm thinking of some kind of substance abuse.
Okay, could be. Jayanti, anything you want to suggest? You agree with that? Hello? Very quiet. Tanushri is very quiet.
I'm actually confused between anorexia nervosa and cannabis abuse. Some kind of substance abuse. So these are the two things that I'm a little confused about.
Not hyperthyroid.
Anorexia nervosa is also another option actually.
Bulimia. So why not bulimia?
In bulimia, there will not be significant weight loss.
Yes,
Anorexia,
exactly.
there is weight loss will be significant.
Okay, that's the important question. So that is important. What do you say about weight? She may have lost some weight, but not sure.
She has lost some weight.
So what does that mean? Okay, are you wanting to know the
So my
answer?
final
Move
choice
on.
will be anorexia nervosa.
Now I
Okay,
go
all
for
right.
bulimia. Bulimia is more
You go.
because there is no significant weight loss. So
Okay, anyone else? Jayanti? What is Jayanti saying? Come on, unmute and answer. Commit. The exam you have to commit. There is no sitting on the fence.
You have chosen the most confusing question, sir.
Cannabis. And Smita, just unmute an answer. Or you can put in the answer in the chat box.
Bulimia.
Bulimia. Okay. All right. Okay. So let's see. Let's see where we are. And answer is bulimia. So who was that? Who got it right? Who was bulimia? Jayanti. Jayanti was anorexia. So no. Was it Smita?
Bulimia.
Smita. Yeah, you said bulimia. Okay. So let's see why. Why bulimia? So patients are generally of normal weight compared with anorexia when they are very underweight. So even so, bulimia compared to anorexia, they are even when they're underweight, they are almost normal for themselves. Do you understand what I mean? So that was the major thing. Bulimia, the weight is not a major severe thing. They're saying that they're not very sure about the weight. So that was the key. That was the key to the one of the. We are coming to that.
What are the marks?
And I one by one. Hold your. All your answers will come. And it's most common in adolescents and young females. Again, bulimia is more common, they're saying, than anorexia. So think of that first. So what happens in bulimia? What happens in bulimia?
Binge eating and then vomit, forceful vomiting.
Yeah, they do that, isn't it? And they conceal, they try to hide by purging and often deny that they're unwell. So they will say that, no, we are fine. The Princess Diana used to have that, you know that, no? She was, I think, bulimia, I think. Yes, she used to binge eating, yeah. She was bulimia, yeah. So presentation varies, but patient complain of fatigue, weakness, abdominal pain, and menstrual disorder. Examination can reveal evidence of purging, marks on hands from post vomiting. So obviously it's very new to us. Apparently, when they keep putting their fingers in their mouth and try to, keep vomiting, so apparently that causes some marks. Now this is very new to me as well, but that's what they're trying to say. So it's not IV. You thought of IV marks, cannabis or some sort of intravenous marks or something. Is that what you think? So, but you see, that's what I would think as well. So basically, what are the physical signs? So marks on hands from post vomiting, because that is a common thing. Dental cavities because of loss of enamel, and enlarged salivary glands. So these are specific of bulimia, and obviously evidence of malnutrition and dehydration. But I guess again these would be anorexia also. I would perhaps guess they would have the same. Dry skin, thin hair. But again, it is confusing because even in hypothyroidism, you can get dry skin. You can get thin hair, isn't it? So that's a bit tricky. Then again, peripheral edema and peripheral neuropathy because there's lack of vitamins. Yeah, but these are not very specific because it could be in hypothyroidism as well. You there with me? So main clinically, it is basically weight loss is not that bad. That's how distinguished from anorexia. Fatigue, weakness, abdominal pain, and menstrual disorder are all there. And repeated vomiting is the main thing. So there's marks on hands from vomiting, dental cavities, loss of teeth enamel, and enlarged salivary gland. And these are sort of common features, peripheral neuropathy as well. Signs of dehydration. Okay. So next question, all right? Question 3. You happy to do this? So Neetu, who has not done a question yet? Neetu, do you want to go through this question? See how you feel? How does that helpful?
A 14-year-old female is admitted to pediatric ward after ingesting 25 of 500 milligram paracetamol tablets. She states she did it because life is not worth living, as her boyfriend of 6 months just broke up with her. She has a stable family background and a good relationship with her parents. She bought 1 packet of paracetamol from a local pharmacy and found the rest in the bathroom cabinet at home. You start her on an acetylcysteine and the following morning refer her to a community and adolescent mental health center. Of a suicide attempt should increase your again.
So which feature of suicide attempt should increase your concern that the individual may attempt suicide again? Yeah, that's the question. A 14-year-old has taken 25 of 500 milligram paracetamol tablets, and she's, she thinks not, obviously boyfriend has broken up, she thinks not worth living, but stable family background, yeah, good relation with parents. And she bought one pack from paracetamol from the pharmacy and found the rest in bathroom. So you obviously start off in the emergency parvolex, which is N-acetylcysteine, and you referred her to the CAMS, which is the Community and Adolescent Mental Health, which you have to know about. So what do you think is a feature which will make you worry where this is a high risk that the child might commit suicide again?
Mainly
Anything?
her intent and where she does it, whether she does it in her own home without the presence of anyone at home, taking a fetal dose of paracetamol. She doesn't want anyone to save her or take her to the hospital. Her unwillingness, she's being unhappy on being, taken to the hospital. These are some signs which could show that she might attempt suicide again, because her intent was to get rid of her life and not to show off or not to create a
Absolutely.
Fear.
Very good. Who's that? Is that Neetu or Jayanti, or who's that? Smita? Who's speaking?
That's me, sir.
Anushri. So yes, because obviously it is whether to, some people do it as to get attention, more of getting attention rather than actually there is a wanting to do it, say the intent, whether it is sincere or not. So let us just go through, see what the few things are. So anyway, they just want to know what are the question is, obviously they have just given a scenario, but out of these, what do you call, choices, which one is, what do you think is, more suggestive of child, wanting to go for seriousness of the high risk that the child will go for, suicide again. Some of it is very clear cut. So female sex, is it more likely that the person will have suicide again if it's female compared to male? Yes or no? Who has more risk of suicide, male or females? Anyone know the answer? I'm surprised.
It is a female sector.
Do you think females are more risk of doing suicide?
Yes.
It is males females might attempt, but males are the ones who are more successful. So basically, females do it to get the attention, and the ones who actually make business are the male
Successful attempts are done by the
males, not females. Yeah. History of schizophrenia, does that have any role? Anyone? We'll go through the answer. Well, the fact that someone has attempted suicide in the form of hanging, does that put the child at more risk or less risk? It's quite obvious. I don't know why you're taking so long. So if there's a history in the past that this person attempted suicide in the form of hanging, would that be more serious, or would you take it that's not that serious?
It would be serious, sir. Attempted suicide in the form of hanging.
Yeah, obviously it is serious, isn't it? That means it would be concerning, isn't it? What they're asking is, does it mean that you'll be concerned or not? Yes, you will be concerned.
Yes.
Yeah. And what about supportive family structure, good relationship with parents?
These are actually deterrents from committing suicide. Actually, if you have a good family structure, this will probably keep you from making an attempt again if you have a good family relationship.
Okay, so what about suicide note? What is the importance of suicide note?
Suicide notes are usually written by people who are intent on committing suicide, who are sure about their decision. They have proper planning.
Absolutely. So that's the one. So in this scenario, what they're saying is they just gave a scenario, but basically they're trying to find whether you know what are the higher risk of suicide, which is a serious risk factor. So obviously, if you had a suicide note, that would have been a serious, that the person is serious, high risk of suicide. If you had a family of bad, the problems in the family structure, that would be high risk of suicide. The attempted suicide is high risk of suicide. Mental illness and all, surprisingly, I think it's not very much linked to suicide.
Except for male sex is,
yeah, but not schizophrenia. I think you're right. Not maybe depression, but not schizophrenia. You're right. Thanks for pointing that out. Female sex, yeah, not a male sex, not female. So let us see the description. So suicide is the third leading cause of death among adolescents. And risk factors are male sex, broken home, disturbed relationship with parents. So broken home could be with husband or anything or boyfriend. Disturbed relationship with parents, living alone, high risk. Immigrant, we all know that immigrants are high risk. Recent loss of stress. So very often someone has lost a job or recently broken up with a partner. Previous suicide attempt. So that's a that's a very serious thing. And obviously drug or alcohol addiction is a very serious matter. So these are important ones. Okay. So still got the energy for another question? Yes or no?
Yes, yes, sir.
Mm.
Definitely.
I can't hear any other voices. I think it's only one person.
Yes, sir.
Who's that?
Smita.
What about the others? They gone to sleep?
Sir, we
They're
all
awake.
are interested, sir. Please continue.
Okay. Okay. So you have to give me the energy. You have to charge the battery, then only the mobile will work. It cannot be that you will just stay like that and have
So
something else and
what is the first leading cause of death among adolescents?
what is the first? This is the third leading
Leading
cause. I
cause
don't know
of
the first. You find out next time you tell me.
the road traffic accidents.
Yeah, I think you're right. I think you're right. You're absolutely right. Because they do, they see mobiles and they cross the road and all that. It is actually one of the highest causes. Okay. But it's a good question. We need to see that out. Okay, so next one. Violent methods of suicide attempts made in isolated places. So I think, I don't know, someone raised that issue. That was very true actually. So, so violent methods of suicide, hanging is considered a violent method, isn't it? So that is serious. Or suppose someone is trying to cut herself with a knife or something. Attempts made in, but not, where they're trying to cut the veins and all, those are not that. The marks, do you know that the marks in the wrist, when people cut on the wrist, just marks, just scratch marks. Don't not cutting the veins, just cutting the scratch marks. That is not a serious one. Do you know that? So that's the important question. It comes keeps coming up in the exam and all. So just making some lot of teenagers very common for them to make they take a sharp object and they make a scratch on
Mark.
the arm. So that is not serious, okay? But if you're cutting your veins, that is a serious. So they are saying, see, violent methods of suicide attempts made in isolated places. Obviously, someone living alone and written suicide note. Significant factors that make the individual to attempt again. Only a minority of adolescents who attempt suicide have an underlying psychiatric disorder and not necessarily a risk factor for future. So in general, what they're saying, obviously, that you know, psychiatric problems are not a major factor. It's only minority of the adolescents who are having problems. They will cause suicide. Okay, so we're going to the next one. So who hasn't done a question yet? I think Smita, you haven't done one. Smita, you want to read this?
A 15-year-old female. Shall I start? A
Yeah,
15-year-old
Yes, yes.
A 15-year-old female comes to you requesting a termination of pregnancy. She tells you that her boyfriend is 17 years old. Having asked several questions about the relationship, you do not have any reason to suspect that it is abusive. The patient seems to be mature for her age and understands what you're telling her about her options and appears capable of deciding for herself what she wants to do. You cannot persuade her to inform her parents that she is pregnant. The girl's mother makes an appointment the following day and tells you that she knows her daughter has been to see you. She says that she's worried about her daughter and asks you to tell her whether you have given her daughter any family planning advice. Which of the following the most appropriate action under these circumstances?
So you got this, yeah? 15-year-old comes to for termination of pregnancy. Boyfriend is 17 years old. Okay. And just give me a second. I'm just answering a call. Just go through this. I'll just mute myself one second. 1 second. Just give me 1 second.
So could we see the next slide, please, for the options?
Sorry about that. I had a call from the hospital. Okay, so basically 15-year-old, yeah, termination of pregnancy, boyfriend 17-year-old, and so not about abusive, mature, she's understanding, and she cannot tell her to inform her parents that she's pregnant. She wants to do it on her own. The mother wants to know what's going on. So what is the most appropriate? So go through the options, someone. So who was doing the, was it Jayanti or Smita? Who was doing the question? Can you just go through the thing?
So I'll read this.
Yeah, just see what is it.
First
Read the
option
choices.
is, yeah. First option is reassure her mother that you have provided her daughter with family planning advice, but do not tell her that the daughter is pregnant. Second one is tell the mother that the daughter is pregnant on the basis that you believe that doing so in this is in the girl's best interest. Third one is do not give information to any of the above. Fourth one is tell the social services. And fifth one is inform the police because underage sex is against the law, and do not tell the patient or her mother that you are doing so.
So what do you think?
Social services. But I don't know why.
It's okay, but it's not that straightforward. So we need to see what you're thinking about. So why social services?
The girl is basically she is not. I mean, it was not a forced. It was a consensual sex. So it was not forced as per the history. So and the mother cannot take the decision over you, and as being a doctor, I cannot keep her ignorant about the fact also, and I cannot tell her also because the daughter's choice. So I think so I'll involve the social services in between for that.
What do you think they'll do? What's their job? How will they help?
They will take in confidence, both of them, speak to them, I guess.
No, it doesn't work like that. You're just basically adding what
is just wanted to ask, in the UK, is a 15-year-old is in a position to give consent for any operative procedure done on her?
We come to that. So that's what they're checking. So that's what they're checking, whether you know it or not.
I think tell the mother and the daughter is pregnant on the basis that you believe that doing so is in the girl's best interest.
You tell the mother, daughter is pregnant. Anyone else who's keeping quiet? Neetu is keeping very quiet, I think. Neetu? Anything? Or maybe she's having dinner. Hello?
She is not at the age to give consent for termination or any.
I have no idea.
No idea. If you're not on camera and you're not saying anything, I'll assume you're having dinner. Any idea? No. Okay. So basically, most people are saying that tell the mother, daughter is pregnant on the basis they believe that doing so in the girl's best interest. And I think was it Jayanti who said that tell the social services. But no one thinks about going to police and all that. Yeah, no police. No? And not about reassuring mother that you have provided a daughter with family planning advice, but do not tell her daughter is pregnant. Okay. So partial information. Partial information. Yeah, half the information. Other such. So let's see. This is interesting one, isn't it? So let's obviously do not give an information, but let us see. So at 15, your patient is not yet legally an adult, but if you judge that she has the capacity to make a decision about disclosure of information, she is entitled to confidentially on her own right. Okay, so even though she's not an adult,
What
but if
was
you
the
feel,
correct answer, sir? What was the correct answer?
what do you think? What do you think? Do not give information to any of the above.
Any of them. Oh my goodness.
Yes.
In India, probably you will be bad.
You will be in jail.
You'll be in jail.
That's why it's UK exam. That's why it's UK exam. And that's why Indian candidates fail in this with this sort of question.
Exactly.
So 15, now you understand why we fail. That 15-year patient is not yet legally an adult, but if you judge that she has the capacity to make a decision or disclose her information, so it's your judgment as a doctor that how conscious she is to ability to take her decision, how mature she is, and then you can decide. So whether disclosure information whether she's entitled to confidentially or on her own right. So that is quite a tricky part. Now the capacity of a person under the age of 16, under the 16 is someone was asking what is the age of consent, 16. But the capacity of person under the age of 16 to give or withhold consent. So whether when you're deciding, so someone is under the age of 16, because 16 you can give consent, that is everyone knows that. But under the age of 16, like this girl is 15, whether she has the capacity to give the consent or not, you are going to decide as a doctor, and this is called as Gillick or Fraser competence. This particular law is called Gillick or Fraser competence after a case. There's a very long-lasting case, in the UK, in London, I think, Gillick versus West Norfolk and Health Authority, okay, which was considered by law of the Lords. There was a long court case, and after that, this was the judgment. So basically, lordship means the law held that in certain circumstances, a child under 16 can give valid consent without parental knowledge or agreement. So certain circumstances under 16 can give valid consent without parental knowledge or agreement. So there is no duty to report a crime. So you don't have to report a crime. There is nothing that you have to. It's not a crime that you have to report to the police. But if you feel that disclosure is necessary to protect a patient from serious harm. So suppose you suspect that she was been abused by an 18-year-old or something, then you should take action. But obviously, best thing is in child protection, you should always talk to her in the hospital setting. So senior experienced colleagues. So you can talk to a senior registrar, or you can talk to a consultant, especially in child protection, or someone who's a child protection lead. Sometimes if you have got suppose 5 consultants in your department, there is usually one pediatric consultant who is the child protection lead. Like all the child protection cases, he will take a decision. So you would probably ask that person. So these are difficult ones. And very often you will be advisable to discuss difficult cases with medical defense organization. So you can call up your MD or your medical defense organization and you can ask them as well. So now you might be, the thing is, many years after, suppose you have acted on a particular case, but you will be called by court to justify why you did a particular decision. And having disclosed or withheld information, it is important to keep a clear record of the reasons behind the decision, okay? So that's it really, that one. Okay, so this is a lot of information, new information, which is vital information, because if you know this, you can save a lot of marks. All right, so you have to know this. This law is very important. Okay, guys, ready for one last question?
If this girl was abused, should the doctor not have informed the parents if the girl was abused?
Say that again. Yeah, that is
Sir,
very good question.
You said
Yeah, you're right.
If there
That
is
is
a
what we
case
are
of
saying
abuse,
now.
supposedly.
So, see here, the answer is here. Having asked several questions about the relationship, you do not have reason for suspect that it is abusive. That was the trick.
I'm putting
so that is the answer
hypothetically,
to your question. That is the answer to your question. If it was abusive, then in her is to protect her. If she's at risk and you think she's being abused, then you would have informed the social services. You might have informed the police in best interest of the child, or maybe the parent as well.
Okay.
So it is in the best interest of the child, because in abuse is obviously a crime, and she's being abused, she's at risk. Very often you might have a 24-year-old child, 24-year-old male, and that is obviously she might be being manipulated. Okay,
Yes, sir.
so that is it really, right? So now we're connected with the last one. Happy to do the last question? Yeah.
We could go on, sir.
Hello. Yeah, tired already.
Yes, yes.
Missing
No,
dinner.
sir.
Oh, it's a good, interesting. So who wants to read the last question and finish up so that we can have all our dinner? Who's a volunteer?
So I'll
Come
read the
on.
last question.
Who's that?
That's Tanushree, sir.
Tanush, carry on.
A
Carry on.
16-year-old girl presents with a history of whitish and clumpy vaginal discharge. She noticed this discharge today after having soreness and irritation with itchiness for the past 2 days. A past medical history of type 1 diabetes and smoking 10 cigarettes per day is noted. In addition, she is on oral contraceptives, as she admitted having unprotected sex during the previous week. Clinical examination reveals a vulvar erythema with thick and adherent cottage cheese-like discharge. The glycosylated hemoglobin was 93.4 millimoles. This high. Okay.
Yeah.
And which of the following is the most appropriate management for this patient?
Okay, so 16-year-old, after someone mute yourself, I think some background noise. 16-year-old, whitish and clumpy vaginal discharge, soreness, irritation, itchiness past 2 days, diabetes type 1, smoking 10 cigarettes, OCP, unprotected cells, everything she can think of she's having. She's having smoking, she's having diabetes, unprotected cells, everything. Clinical examination revealed vulvar erythema with thick and adherent cottage cheese-like discharge. High HbA1c, so what is the appropriate management? Which of the following? Clindamycin, intravaginal cream, oral metronidazole, estrogen, local emollient, oral fluconazole. I think these you should be able to answer. Come on. Who's for clindamycin? Anyone? No? Oral metronidazole?
Oral fluconazole.
Who's that? Yeah, oral fluconazole. So no need of local things, local treatment. Oral fluconazole, anyone else supporting this? You can write in the chat box if you're feeling too tired to write. So Jayanti has said oral fluconazole. What about others? Tanushri and Smita, whatever, Neetu. If you have not dozed off, please, please give your answer. Hi, Neetu, want to hear from you. You can type in the
oral, this girl is immunocompromised and the infection may be likely candidiasis. So oral fluconazole may be the quick management.
Okay, fluconazole. Smita, is that Smita?
Yes, fluconazole.
What about it? Fluconazole, everyone agrees? Neetu? Hello? Dr. Neetu, are you there?
Fluconazole.
Hello?
It's oral fluconazole.
Okay, so house says fluconazole. And you're right. Absolutely right. Now let us see the choices. Very interesting because you guys should know that anyway. So vulvovaginal candidiasis is not uncommon, especially in uncontrolled diabetes. So vulvovaginal candidiasis is not uncommon. The diagnosis is always clinical and provided good history is taken. So vaginal candidiasis is not considered an opportunistic infection because it can happen in healthy individuals. So there's a difference between vulvovaginal candidiasis, which happens in uncontrolled diabetes, and and vaginal candidiasis is not considered opportunistic infection because it can happen in healthy individuals without risk factors, and is not considered as sexually transmitted. In this patient, there are several indications of vaginal candidiasis like irritation, vulvar erythema, cottage cheese-like disease. So basically, we are dealing with vaginal candidiasis, and what we saw, vaginal candidiasis, it can happen, individual without risk factors. The diabetes is not sexually transmitted. Okay, that's fine. And these symptoms do overlap. So there is some overlap with other conditions like these can be excluded by the strong history consistent with candidiasis, diabetes, and smoking. Okay. Now, metronidazole and clindamycin, they are used in bacterial vaginosis, and a lot of questions keep coming up on this. I've seen a lot of questions. They always try to confuse you between bacterial vaginosis and vulvovaginal candidiasis and the treatment and all that. And estrogen therapy. Estrogen therapy is used for atrophic vagina. It's not used in this case. And local emollients, what is the use? They are used in vaginal irritation, nothing to do with treatment of fungal infection. So that's what they are trying to say really. But it's good to know that because we have to know estrogen therapy is very often questions keep coming up. Metronidazole, clindamycin very often. So you have to know very clearly which is from what. Bacterial vaginosis. Okay. And obviously fluconazole, oral fluconazole is the drug of choice. And as you saw, diabetes and things like opportunity infection, then that is the drug of choice really. That's it. That's the end. What's the time now? We finished on time?
Yes,
Right.
sir.
So it's about 10 to 10 minutes past. So thanks you everyone. I hope that was helpful.
Yes, thank you,
Was it?
sir.
Yes, sir. Yes, sir.
Thank you,
The
sir.
questions are very
So I hope,
tricky.
yeah, it was worth your time. Yeah.
Yes, sir.
So
Yes, sir.
let's show our faces before she says goodbye. And then we'll say goodbye. We'll just show our faces each so that I know that you're all awake. There,
Bye, sir.
Tanushi. Thank you. Jayati, thank you. Smita. Neetu,
Yes, sir.
thank you.
Thank you, sir.
There you are. Okay. Bye-bye. So I'll be doing this
Bye-bye.
once a week. Yeah, once a week, mostly Mondays. If it's not a Monday, probably a Wednesday. All right. And you can suggest any topic you're particularly interested in. And you can call your friends. So, this is what I'll be doing. Okay, I hope it's
Sir,
useful.
just to interrupt
Thanks a
you.
lot.
Sir, hello.
Yeah, carry on.
Yeah, I was planning to take the June exam for the part-time test. So the window has not yet opened, right, sir? It's window for
So that you have to
booking.
check. See, that you have to check. No, you have to check the website for that. You have to check the website. I think if you're in the Telegram group, I've given a list of which exam when the windows are going to open. If you see, you're in part of the Telegram group, no? Dr. Academia
Yeah,
Telegram
I
group.
am. Okay, can you
If you see
resend it?
if you have a look, I'll try to resend it. But there's a list of when it is opened and not opened. Yeah, there's a lot of information there. Okay.
Okay, sir.
All right.
Okay, sir.
Take care. Bye-bye.
Thank you. Bye-bye.
All right. Take care.